The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another issue of the Genuine Article. And today I'm talking with Dr. Massimo Caputo. And Dr. Caputo is a consultant surgeon at the Bristol Heart Institute in England. And Dr. Caputo and Associates are about to publish a very important paper in JACC, we believe, that deals with the role of ACE inhibition in patients undergoing cardiac surgery, specifically coronary artery bypass surgery. So, Dr. Caputo, can you tell us a little bit about the design of your study?
Yes, this is a retrospective study which is based on our database, which is a very big database where we prospectively collect data on all our patients undergoing cardiac surgery and obviously patients undergoing coronary artery bypass graft. And the hypothesis was based on the observation that patients taking ACE inhibitors before CABG surgery, they tend to have low arterial blood pressures in the postoperative period, and therefore we wanted to see whether the effects of angiotensin-converting enzyme inhibitors therapy can affect clinical outcomes after patients after CABG surgery, really.
Yes, so this has been a controversial area, whether ACE inhibitor therapy causes problems during cardiac surgery or whether it's beneficial, and the literature is a little bit mixed. You had a very large population to look at. Can you tell us what you found?
Yes, what we found was that patients who were taking ACE inhibitors up to 24 hours prior to surgery had worse early clinical outcomes following the CABG surgery. And this was in terms of looking at several endpoints, including mortality, postoperative arrhythmias such as atrial fibrillation, postoperative renal dysfunction, and the use of inotropic support.
Okay, so your data kind of convincingly showed in this population that ACE inhibitors was associated with these adverse effects. But of course, one of the major limitations is that this is a retrospective observational study, and you use propensity matching, but still, one can never be sure that one has addressed all the variables that contribute to whether a patient receives ACE inhibitors or doesn't. Do you want to comment on that?
Yes, 100%. There is always this argument when you do retrospective study that you are comparing, apples with oranges, and the strength of this study is the big sample size, and we know that the big sample size is required when you have to demonstrate differences in endpoints which happens in low frequency, such as mortality. So on one side, we are reflecting what we call the real world of CABG surgery, because these are all patients coming in and they are put in our database. On the other side, it's not a prospective randomized study. So that's definitely a limitation. Nevertheless, we know that to reach that sample size, you really need to have a very big multi-center prospective randomized studies. And at the moment, in this field, there is none of this entity.
So have you stopped ACE inhibitor therapy in the patients that you're taking to bypass surgery at the current time?
Sorry, say again. I didn't get that.
I say, have you begun to discontinue ACE inhibitor therapy in the patients you are taking to cardiac surgery?
Yes, that's correct. Now, at the moment, for all the patients coming in with ACE inhibitors, we discontinue them at least 48 hours, between 24 to 48 hours before surgery. And that's taking into account that the half-life of ACE inhibitors varies according to the different type of ACE inhibitors, but the policy is to discontinue them for sure.
Right. Well, I guess in the absence of a large randomized prospective trial, that some controversy will continue, but these are important data on a very large group of patients, and it certainly points out that the use of ACE inhibitors really should be considered significantly in patients undergoing coronary bypass surgery. For the Genuine article, I'm Tony DeMaria.
The Genuine Article. Discussion and commentary based on articles from JACC.